the authorities should get up and put regulations in place. Otherwise, we are putting our young women at risk.
We are always striving to reach the top, no matter what.
I was chosen not because I was a woman. I was chosen because when I went for the interview, I seemed to have everything that the Ghana Chamber of Mines wanted.
We are frank about who we are.
I deal with mostly women. Even though I deal with men, most of my clients are women. And you know, we women,
I don't know really.
And in today's world, we do have a say.
Actually, they are dead drunk. We do have a voice. With that voice, we can change the world. With that voice, we can take command of our broken communities.
Women's Voice, weekdays on GBC 24 at 4 p.m. and on Mondays and Thursdays on GTV at 4 p.m. Women's Voice, articulating the issues affecting women and sharing their unique stories with the rest of the world.
Many thanks for joining us. This is Women's Voice, and my name is Selike Makola Chiapalu. You're welcome once again to the program. As you know, on this platform, we look at issues affecting women within our society and also sharing their unique stories with you, our audience. Once again, you're welcome. Today on the program, we're looking at reducing maternal mortality, the case of Northern Ghana. Ghana failed to attain the MDG 5, which is to reduce the number of women who die in pregnancy and childbirth by 3/4 between 1990 to 2015. When applying this target to Ghana, maternal mortality should fall to 145 cases per 100,000 live births. I'm not sure if I'm getting those statistics right, but those statistics are out there. Currently, Ghana's maternal mortality rate is 3 times higher than the given target. And obviously, the country could not achieve that target. We are almost ending the year. We are in 2015, and the year is just about ending. We have made some progress in terms of tackling maternal mortality, which is great. But does this target reflect the national picture? What is happening in Northern Ghana with regards to maternal health? What do we know? Now, we know that Send Ghana, a non-governmental organization, has launched a report on a study conducted into the funding to support maternal health services in the 3 regions of the north. We know that the northern, upper east, and upper west regions significantly lag behind when it comes to reducing maternal mortality. And so this is why today we're looking at reducing maternal mortality, the case of Northern Ghana. My guest with me in the studio, as we'll be looking at the issue, seated to my extreme left, I have Clara Osei Boateng. She's the Director for Policy Advocacy Program at Send Ghana. I also have here with me in the studio Dr. Patrick Abuaji. He's the Director of Family Health Division at the Ghana Health Service. You're all welcome to the program. And I saw you nodding, shaking your head. Otherwise, in that introduction, there are some corrections you'd like to make, Clara, before we begin.
Yeah, I think the target for Ghana MDG 5 was 185 per 100,000 live births.
100,000, yes.
Yes.
Okay, not 145.
Yes,
so that correction is out there. But when we talk about
and our current maternal mortality is 319.
Yes, we'll come to that. We'll come to that because I did not mention that in the introduction. So let's start from the basics. For those who do not understand, when we talk about maternal mortality rates, what exactly do we mean? And I'll start from you, Dr. Patrick Abuaji.
Thank you very much. When we talk about maternal mortality rates, it's more of a risk.
Right.
It is the number of women who died in pregnancy, either during pregnancy, 6 weeks after pregnancy, or any cause related to pregnancy, either because of the pregnancy. So, for example, if you are diabetic and your diabetes exacerbated because of the pregnancy, it can still be classified as maternal mortality, even if you die from diabetes in pregnancy. And so, and we do that comparing with the number of live births that are given. So we are looking at the risk of, so for a number of women who have 100,000 live births, babies born alive, how many women will die? And that's how is calculated, and it's done specifically to ensure that we are measuring the risk of that, so that there's something to compare, so we can have an international comparison instead of just talking about absolute numbers.
So the international comparison now is what in terms of the MDGs?
Well, in terms of our status,
MDG 5. Yes.
Our baseline for MDG was 760 maternal deaths for every 100,000 live births. As at 2015, as the figure that we use in entering the MDG, complete MDG was 319 for 100,000 live births.
Right. So what can we say about that? Are we making progress? What does that mean for Ghana?
Well, that means that the risk of dying from pregnancy has reduced significantly. That also means that for the MDG target of 75%, we've done about 58%, as again the 75%. Also means that the number of women aged between 15 and 49 who die as a result of pregnancy has reduced from about 28% to close to about 11% also of that risk. So in terms of the risk of dying among that group, it has reduced. Right.
So Clara, can we say conclusively that we have not been able to meet the MDG 5?
Yeah, I think that is pretty known, that by this time Ghana is unlikely to meet the MDD targets. And from the statistics that he gave, 319 compared to our own target of 185, then surely we will not meet it. But the good thing is that, when you look at the current, the SDGs have replaced the MDGs. And if you look at the targets, it's just building on the MDGs. So it's work in progress. And so therefore, we still have, the challenge to work harder to reduce maternal mortality. And as I indicated, the quest to reduce maternal mortality shouldn't be just an MDG target. I mean, every life counts. Who should be in that 185, even if we are to achieve it? No woman should actually lose her life when she's bringing a new life into this world. And so that challenge is still with us to strive harder and at least get to that point, get to, a time will come that in this country, there are countries that do about 2 to 100,000 live births if you go to the developed countries. And so that's what we should aspire to as a nation, because I don't think that any family will be pleased to be, to have a family member among the 185, even if we are to achieve it.
So in 2012, we launched a national emergency, that's the acceleration framework. How did that work out for us?
Through our assessment, I had a conversation with a coordinator for the how it's been going. I think it was a comprehensive framework that was to help us accelerate our progress towards achieving it. But funding, as far as the information I got, hasn't actually come through as expected. I think 52 million euros was committed, and as of September when I spoke to him, only 10 million euros had been released, and this was done in 2013, and the rest had not come. Of course, there are challenges. When donors are pumping in money, sometimes there are some conditions. If you do not meet them, the monies do not come. So financing has been a challenge, and which is one reason why our report focused on financing, because there are multiple factors that contribute to maternal mortality. As infrastructure and all that, but we decided that we'll focus on financing bits to see, because in any research, you can narrow down your focus so that you understand a particular variable much better.
Right. In what form did you conduct this study?
Basically, St. Ghana's work, we adopt a citizens-led approach. And so in each of the districts that we operate, we have citizen groups in place. And what we do is that technical staff lead them. We develop data collection tools like questionnaires, focus group discussions, which are sent to district health management teams and also district health facilities. And this particular research focused on district health facilities and then this district health management teams. And the reason why we focused on the district health facilities was that one, we had another project which was looking at the lower level healthcare system like CHPS compound. And so then we wanted to look at the middle level, at the district level. And importantly, in every district that you go, the district health facility is the highest, and that's the last resort. And so if that facility is not well resourced, then you can imagine what the bottom ones are. And so we thought that the district health facility plays critical role, because when the woman is at the, that point, that's where everybody looks to rush her to the hospital. So we wanted to assess the situation at the district facilities to see that whether or not they are ready or they are delivering quality health care to save the lives of our mothers.
Right. This must have been a comprehensive study. Over which period?
We started actually in Ghana. The biggest challenge we face is data collection. So data collection alone took us over 5 months. We started in January and it was completed around May in collecting data. And so it was quite comprehensive. And then again, you have to validate the data with the assembly. So when we put them together, we take the data back for them to validate the figures they gave us. And it takes some time now. So it's taking us quite.
Right. So which institutions were behind this apart from St. Ghana?
This is Improve project. We call it Improve. That is work towards contribute to maternal mortality reduction in Ghana, and is a European Union funded project, and we are doing it in collaboration with Christian Aid.
Right, so we are now looking at particularly the case of Northern Ghana, Upper East, Upper West, and the Northern region. Why do we see disparities in achieving, reducing the maternal deaths in the northern part of the country as compared to the southern part of the country? Just oppose that against the national average figures.
Well, thank you very much. We've always known maternal mortality is generally a development issue.
Right.
And so many factors come in play, not just health, access to roads, your bridges, the human resource that is there, access to facility, the distance from community to facility. They all play a role in that. And so when you compare the north and the south, you realize that even for the infrastructure base, there's that huge deficit. In fact, where we have the longest distance from facility to hospital, it's usually the northern region, which means that we have a significant proportion of women who, when they have a complication, will spend more than 3 hours to reach care. For conditions like hemorrhage, when you are bleeding, within 2 hours, if you don't get care, you could die. So they all create some of the problems. Apart from that, even the healthcare, the staffing situation is not as good as other parts of the country, and that is also a factor. Generally, your ability to reach care depends on your finances, and then so somehow poverty has a major role to play in how you access care in terms of the demand side of the care. So all these parameters tend to play in the way of making the risk of dying from pregnancy much, much higher there than there. Even if you look at, across the country, the risk of being in the rural area and urban area is higher in the rural area than urban area because of the same factors, except of course now that some places like Accra and Kumasi and Accra, because of the traffic, the distances are not a problem, but the time to reach care is also becoming a problem. So those are some of the, I would say, the most underlying conditions under that. We also have also the whole issue of, I talked about poverty, educational level and status, and so your ability to plan and prepare also.
Even economic empowerment, isn't it?
Yes.
Because having the ability to be able to carry yourself even to the health facility, if it's, you don't have the means, then how do you even get there in the first place? Okay, so your report looked at the funding aspect of it, but why did you focus on funding specifically, and how do they go to affect everything else?
Yeah, as Dr. mentioned, there are quite a number of issues which affects maternal mortality, can affect a woman's ability to deliver safely or not. And so we look at all these, and in our previous projects we've looked at other issues like NHIS and things like that. And so given that this is 2015, the end of MDG, and Ghana signed up to committing to deliver the target that is set, we wanted to see how governance of these has really worked, how government has committed financial resources to implement this framework and other projects that we have. Because there's one thing, adopting a policy, and is another ensuring that it's well implemented. And so we decided to focus on finance and to see how it's going. And especially so that in our other engagement, we do a number of health projects. In one of them, we've actually provided opportunity to build the capacity of health staff and even community health volunteers and others. And one of the complaints which was coming up was the issue of financing. And so we really wanted, there were some areas we go there, and when we talk about engaging with them, they would say that instead of you to come and give us the money to work, which is not how we work. And so we wanted to understand why there's so much I mentioned about financing. And so we went into that to assess commitment from the central government to financing maternal health programs at the local level, and so that informed that. But I must say that some of our interventions has also brought about the other related cases. For instance, during our engagement with communities, we found in some communities that their major challenge was transportation. And so the communities, through our sensitization and engagement, they agreed to set up their own fund where they contribute. Individuals contribute, and some of them have been able to contribute and procure what they call the motorcane, and that's what they use as an ambulance. If I had a picture here, you would see the way they've decorated the motorcane, and that is a huge relief, because you go to some rural areas, when a woman is in labor, they have to carry her in a wheelbarrow, sometimes at the back of a motorbike. And so then the motorcane is more than an ambulance. And so we've been able to intervene in other areas. But of course, as we will say, there are certain things that must be done by government, and civil society or private sector cannot do. And that is one of funding, health facilities. We think that is the responsibility of government to do that. And therefore, we wanted to bring that issue up at this important moment that we are finishing off with MDGs and going into SDGs, so that we can raise the concern. We know government is aware, but of course we want to highlight it so then they see how important these issues mean to us as citizens of Ghana.
And I want to come to our signing on to protocols and conventions. We signed on to the Abuja Declaration, and we're supposed to be devoting 15% of our annual budget to healthcare. As to how much of that percentage goes into maternal care, that is another issue. But so far, we dedicate about 10.5 to about 12.5 of our budget to healthcare. How is it that we are not able to meet up with the declarations that we ourselves as a country have signed on to, Doc?
Well, thank you very much. I think there are certain years, I'm sure Sen will tell you, that the nation has actually hit the 15%. But it's 15% of a certain type of cake. Depends on the size of the cake. So even as we those of us on the field who are working, we are more interested in the per capita expenditure and not the percentage, because there are countries that are spending just 4% of their budget on health, and the amount of money involved is huge.
Scenario. Yeah.
So I think we must focus more on the per capita expenditure, because looking at the economic growth, 14% of the now 44 percent of our 44 billion of our money is not the same as, say, the 15% when we had, let's say, a budget of 20 billion. So there are, but I'm sure none will tell you that in terms of the actual quantum of money, it has significantly gone up. But if you are looking at the size of the pie, you may think that it's not. But maternal mortality is not just a health matter, and so somebody must build the road. Somebody must make sure the bridge that leads to that village is working. Someone must ensure that people are educated so that they can also be able to empower themselves to access the care, and also reduce the level of ignorance that also affect the demand for care. But I believe that being in the health sector, I think there's a lot of effort, not only to get government money, but also mobilize resources from other development partners to improve health. But I think we all agree that we are not a very rich country. We have challenges.
Middle income.
A lower middle income.
And perhaps we didn't anticipate our energy challenges, did we?
Yes, and so some of these things will come out to affect how much has been spent, but I'm sure a lot more has been spent. And also I think a lot of our partners have not given us the resources that they have promised. So they all have somehow effects on these outcomes. But my greatest challenge is that it is not a health alone matter.
So how then are we collaborating with other government agencies to get on board to do this together?
Yes, we are doing a lot of collaboration with the local governments, and I'm sure Sen will tell you how many, some have bought ambulances, some have built clinics in villages, in the local government. And we are also advocating for roads and transport to ensure that, okay, if you are building a road, please prioritize the one to the facility, etc. And so there's a lot of collaboration that we are doing, especially with local government, which actually owns the districts, to ensure that access to care is improved. And that we are doing that. And currently, even the local government has taken up on itself to take maternal mortality as a major issue. And I believe that even DCs have to be measured based on their maternal mortality in their district. So I think that collaboration moved on beyond that to make the maternal health more of a national issue and not just a health sector
right.
issue.
And so we have sources of funding that come to fund the health sector, and coming from the government, coming from internally generated funds, and then donor funds as well. What is the proportion of these funds and how do they come in?
I think our assessment showed that largely DHMTs and facilities depend on governments for their funding. I think for about 11 districts that responded, 54% of their funding sources were expected from government. Right. But then there's a difference between allocation and then disbursement, and that's where the issue is. In as much as they were expecting 54% of their estimated revenue from government, how much of that came? And that's where we had a huge concern, because according to the Ministry of Finance or disbursements, on quarterly basis, they are supposed to receive part of whatever was approved for them. And we found in cases where, like, for the first 3 quarters, they do not receive anything. Sometimes it comes in the last quarter. Or the previous year, they didn't receive anything, so then following year, first quarter, they get something. So it's quite erratic. And so a lot of them were actually bemoaning the fact that they cannot plan, especially with the DHMTs. On the other hand, with the district facilities, when
you
DOD...
say DHMTs,
that's the District Health Management Teams, yes.
For our audience to understand clearly.
Yes, the Health Directorates, so let me put it that way. So they are not able to execute their plans. For the health facilities, because they are delivering services, what we found was that even though, you know, in Ghana, likely we have the free maternal health under you register with the NHIS and you access it.
Free maternal health.
Yes. So when you go and there's no money, then they are forced to ask the patients or to bring in this or that. And so people, women go in to deliver and they are given a tall list of items to bring the tall and all that. And so when they calculate it, and when we interacted with some women, they said that when they estimate the cost, they cannot afford it, and so they end up just staying at home and delivering at home because they can't afford to bring those items. And so those were the quite issues that were really we thought, you know, we need to look at, because otherwise then access to the free maternal health services is a challenge when other things do not hinder the access in terms of being able to pay for other things.
Right, so in cases where women are forced to stay at home or end up staying at home, we have the traditional birth attendants within the communities. And these are people who, over time, communities have trusted with delivering children, and they're used to their services. But the question is, do they have the technical know-how and the ability to handle complicated cases? What are we doing about that?
Well, the TPA delivery is actually coming down. Okay. It's dropped from about 30% to less than 14 or so, less than 10% across. So the issue of courage and faith in them, I'm sure, is waning.
Right.
those who are using facility delivery has moved from 40% in the last 15 to 20 years to about 74% as of last year. So we have about 3/4 of all our women delivering with a skilled provider or in a health service. Our concern is that yes, the TBA has a role to play in maternal health, but not necessarily conducting delivery, because the things that are killing our women, the TBAs can do virtually nothing about it. You are bleeding, they can't do much. You have a hypertension, they can't do anything about it. You have an infection. I see generally, despite the fact that we are talking about higher maternal mortality rate, it's still a very rare event.
So are we talking about doing away with them completely? Are we talking about, because there's still women out there who are patronizing their services?
They are not our best option.
Right.
So we are working towards ensuring that all women get skilled care. And that is why we have the CHPS compounds. We are giving them capacity to conduct deliveries. We are training more midwives than before. Now we are doing about 1,000 midwives a year, so that we can saturate all this place. Because I think if you deserve a midwife, so does the rural woman. And I don't think in terms of equity it's fine to leave some women, some Ghanaians to the hands of an unskilled hand. A lot of women can deliver, without any trouble. So you think it is very easy. A TBA can conduct delivery for 5 years and nothing will happen. You've just been lucky, because only about 10 to 15% of all pregnant will develop a complication. So all the work we do, all the resources is towards that 15 or so percent. Because the rest of the women can get pregnant, stay at home, eat the normal food, and deliver, pick the baby and walk away. Nothing will happen. It's the 15%. That's where all the challenges are coming from. So they are not our best. So our policy is for the DHMTs to ensure that as much as possible they build capacity across all communities, so that skilled delivery can be done. At least women will have an option. We don't want a situation where the only option is a TBA.
So for communities that are very far from health centers, we have the CHPS compound. My question is, how equipped are these CHPS compounds? For instance, some of them don't even have weighing scales, basic things such as that. So how equipped are the CHPS compounds that we have within the districts?
I think with regards to that, the Ghana Health Services has actually responded to some of the concerns that civil society has raised. As I indicated, our previous assessment focused on the CHPS, for instance, and we raised some of these issues. The fact that originally they were not intended to do deliveries, but then you see somebody lives in a rural area, they don't have a hospital, and then you come and put a health post. They call them doctors and nurses, and for them that is their hospital. And so no matter what you tell them that these are for basic health care, they will still wait till the last minute when it gets to that complication that they cannot handle. And so we advocated for them to allocate midwives, and as it indicated, it's been quite positive. We've been monitoring in the northern regions, and we are seeing that they are getting midwives and it's improving. In terms of logistics, still the gap is quite huge, but I think that for that we will give it to them. In fact, we were invited to be part of the committee that reviewed the CHPS compound, and we made significant contributions. So I think, like you said, it's not up to expectation, but then they are doing their best now, and I think they need to be commended for that. And also, of course, which is why civil society organizations, we also doing our part. What we did for this year is that in those about 25 districts up north, we actually facilitated trainings for them. We don't do the trainings because we are not experts. We'll provide the logistics and all that for Ghana Health Services to train their own staff. Those are the CHPS compound. Some of the community health committees, they were not working. We've helped in reviving most of them in the districts that we operate. So I think it's, for that I can say that they are paying attention to it currently.
Right. So in your reports, what is the ratio of doctor to patients within those communities where you did your study?
Yeah, I think that one is a national data, so Ghana Health Services will be able to. But for what we saw, it was quite huge.
Okay, so what do we know? What do we know about what's happening in the northern part of the country?
What we know is that we don't have the saturation of doctors there. It's not as high as other parts of the country. Currently, we have more than 30 or so districts that do not have a hospital, so they generally don't have a doctor. And so the population in that district is about 100,000, and it is the population ratio is no doctor per 100,000.
No doctor to 100,000.
But if they have, I mean, we have a significant number of districts that has only one doctor now.
Okay.
And so that also will increase the doctor population ratio. But the national average is about 1 to 10,000. But you can get as much as 1 to 40,000.
In fact, 1 to 50,000.
Depending on the distance. So those are some of the challenges. And I mentioned it all has to do with infrastructure, availability of hospital, availability of commodity, accommodation and things that will be able to infrastructure for us to render those services. But there's a lot that is happening now. The posting committee of the Ghana Health Service is working very hard to ensure that more doctors are posted to the north. We are also hoping that the communities and the assemblies will also contribute to attracting more doctors to those areas so that we can also have a good spread and access to care. On the question of the midwives, we are also having what we call a supervising midwife who does outreach to those areas where there are no midwives, even though there's a CHPS compound. So they also go there periodically to offer services and also provide capacity building for those who are there. But these are all interim measures. But the main thing is to ensure that every community has a CHPS compound and they have a health facility that is rendering appropriate clinical care and manage some complications.
Right. I'm going back to the issue of disbursement of funds. Which institution is responsible to ensure that within the district some money is allocated to taking care of maternal health? Will that be the Ghana Health Service?
Well, that's really not my area.
Okay.
But what I also know is that funds are released from ministry to Ghana Health Service, and those funds are also given to the district for specific. We also have specific program funds like MAF, if it's available, and other part which are sent to the districts and regions for specific activities. What happens is that the regions bring their plan, and so when they receive funds, they implement their plan based on that. That's why it's quite difficult to see how much actually has gone into this.
But how do we know if some bit of that money at least is going into maternal care?
We do what we call the health account periodically. And when we do the health account, we're able to somehow see what was spent on the various programs.
I think just to add to Doug, basically in complying with our budgeting system, all the departments, agencies or whatever, they prepare their budgets. And so what we found is that for the health ones, maternal health is under a broad category called reproductive health. The maternal health budget goes into the reproductive.
It's actually part of reproductive
health. It's part of reproductive health. It's not separated. And so basically, just like other components or budget items that they budget, they put that together, submit it, and when it's approved, they release the monies in tranches. So the monies come. But then when the monies come, it doesn't say this is maternal health or this is that, based on your own program for the year. And
so it's not mandatory that a certain amount goes into maternal care?
Well, according to their plan, if you are assessing them according to yes, then you expect that they will spend on it. Right. But then oftentimes the challenge is that because they do not get what they budgeted for, and then there's the issue of prioritization or probably discretion in terms of where to spend the money. And that is where, if you are not careful, perhaps attention might not be paid to one particular area or the other.
So that discretion comes from the Ghana Health Service?
No, I think it comes the spending
because
institution.
Then some areas get funding, other areas don't. And that reflected in your report. So how is that happening?
At the beginning of every year, we have our priority interventions. And for every district, your top priorities are maternal and child health. And that's the bulk of the things that you do. So it will be difficult for any region not to, or district to have funds and not spend on maternal and child health. The question is it adequate?
So that presupposes to say that the funds don't come?
Well, I mean, they did a study.
Yeah, yeah. I mean,
Because
basically, that's the finding.
in some parts of the study, it says that between 2009 2012, only Agona is consistently received funds from the Ghana Health Service. Suhum consistently received in 2012, whilst Idrak, Mandai, and East Mamprusi did not receive funds.
Okay,
that's the basis for
that's
which
our
I'm
old
asking.
report. Okay, okay, okay. That's not the one we just launched, but we did that as well. That one focused on 6 districts: Amansia West, Ejura, Sechedumase, Agona, East, Suhum, and then Pandai, and then East Mamprusi. That was our previous report that we did. Yes, and so it's the same as this one. So based on that report, we decided to scale it up to 30 districts. So this new one focused on 30 districts because that was a pilot we wanted to understand. And so basically the thing is that according to information we gathered from the DHMTs, the district health management teams and the health facilities, they can go a whole year and they will not receive a penny from government of Ghana. And so then for the health facilities, they become reliant on out-of-pocket payments and then also reimbursement from NHIS. So when NHIS reimbursement delays, as we always know, then it becomes a challenge. And that is when some of them are forced to impose charges here and there on patients because, you know, they need money to be able to work.
Well, I find it strange that districts didn't receive money at all because, I mean, the way the funds are disbursed, there's no way. It may not be enough, but I'm sure every district, and also depends on who you spoke to. And I'll be surprised that
and that's why I'm trying to get the clarity from you, because
that for one whole or others receive, but that's almost a 3-year period. They never receive money. That'll be very strange. That'll be extremely strange.
That'll be strange, but we need to find out why that is so.
I don't think it is true.
Well, we address our questionnaire to the head of the DHMT, and they provide or the head of the facility, and they provide us the data, and so we analyze based on the data. Oftentimes, they will tell you that only compensation comes. Apart from compensation, assets and goods and services and other things do not come, and so that's what we mean by. Because as for compensation, we know that they will be paid anyway, but we're talking about other service delivery. Resources for service delivery, and that's what the reports that they did.
Yeah, I mean, we agree perfectly that the resources are inadequate, but it's also our services are expanding, and then service utilization is going up, and so what it means is that we need more resources to be able to deliver on the services that we are doing.
And how do we get more resources?
Well, like I said, the government is doing its bits, but we're also getting district and regional managers to ensure that they are also able to mobilize resources.
So the general understanding is that the resources are not there. Inadequate resources. Because at the bottom of all of this is that health facilities need the funds to be able to make this work. If we are going to deal with or tackle maternal mortality, it has to work with some resources, and that's why I'm asking that question. This is Women's Voice. Today we are looking at reducing maternal mortality, the case of Northern Ghana. My guest with me in the studio, I have Clara Osei-Boateng. She's the Director of Policy Advocacy Program with Send Ghana. I also have Dr. Patrick Abuachi. He is the Director of the Family Health Division at the Ghana Health Service. We'll take a short break. We'll be right back. Do stay with us. back. This is Women's Voice. Today we are looking at reducing maternal mortality, the case of Northern Ghana. I have here with me in the studio Clara Osei-Boateng. She's Director of Policy Advocacy Program at St. Ghana. And I also have here with me Dr. Patrick Abuaji. He is the Director of the Family Health Division at the Ghana Health Service. You're welcome back. Let's look at attitudinal change, which is also a bulk of the problem, dealing with behavioral change and trying to get people to change. If a pregnant woman even here, it doesn't have to be in rural Ghana, feels that she has to take some herbal concoction to help her to make her birthing process easy, that concoction is not safe for her and something happens, that all goes into the figures we are looking at when we come to maternal mortality rates. What are we doing in terms of outreach, education to try and change the behavior?
I think in enough, a strong influence is culture and probably to some extent religion. And especially with family planning, during our sensitization as community education, one issue that we come across is the fact that most men...
This is Women's Voice. We'll take a short break. We will be right back and the conversation will continue.
It's about exposing the vulnerabilities women face.
But you are in a peculiar situation. You are pregnant.
Yes. I've told that point already. My family is a small family, and my father too is old man. He cannot work again. That's why I'm pregnant and I come here.
It's about being ready to speak out for our own rights.
We are saying that surrogacy unregulated is dangerous for our society. The authorities should get up and put regulations in place. Otherwise, we are putting our young women at risk.
We are always striving to reach the top, no matter what.
I was chosen not because I was a woman. I was chosen because when I went for the interview, I seemed to have everything that the Ghana Chamber of Mines wanted.
We are frank about who we are.
I deal with mostly women. Even though I deal with men, most of my clients are women. And you know, we women,
I don't know really.
And in today's world, we do have a say.
Actually, they are dead drunk. We do have a voice. With that voice, we can change the world. With that voice, we can take command of our broken communities.
Women's Voice, weekdays on GBC 24 at 4 p.m. and on Mondays and Thursdays on GTV at 4 p.m. Women's Voice, articulating the issues affecting women and sharing their unique stories with the rest of the world.
Welcome back. This is Women's Voice. Today we are looking at reducing maternal mortality, the case of Northern Ghana. And before the break, we're looking at attitudinal change. How do we get to educate people on changing their behavior towards these things concerning maternal health?
Okay. So as I was saying, in our outreach, we've realized that in Northern Ghana especially, culture plays a significant role, and to some extent also religion. And for instance, women need the permission of their husbands to go for family planning. And so then if you are targeting only women when it comes to maternal health issues, then you'll be missing it. You need to include the men. So what we've been doing with our public education is that we target both the men and the women, and we give them medication for them to understand. We've also noted that traditional authorities have strong influence in rural communities in the north. Right. And so a lot of the times we target traditional authorities and we get them to push through some of the good practices that we expect. So in our maternal health project, we use the MDGs as community champions, women who have influence in communities as community champions. We developed with Ghana Health Services flip charts and posters on good maternal health practices, which we have given to such women as we call them community champions, and they are doing peer-to-peer education, community-to-community education to help change some of these attitudes, because they do quite influence access to health in that region.
Right. And what kind of feedback have you got from all the work you've been doing?
Well, the feedback we are getting is the fact that access is improving.
Right.
More women are using our services. Women are coming much earlier than before. Now, the last DHS, about 64% national average is coming in the first trimester. Of course, it's much lower in the north due to the some of the cultural things we talked about, and even in-laws and etc. So they are not even supposed to tell you they are pregnant until, say, your husband says you are pregnant. So they are all cultural nuances that affect utilization of care. But I think there's significant improvement across the country.
Right. Let's finally look at recommendations that you will make. You're from the Ghana Health Service, you're from St. Ghana. I'll begin with you, Gladys. Recommendations
I think
on
based on this
tackling-
report, the main one is for government to increase resource allocation. We always say that there are not adequate resources in this country, but we think that health is such a priority that we cannot joke with. And so government needs to pay particular attention and increase resource allocation to the sector, particularly at the local level, because that is where the most vulnerable of our citizens access healthcare.
Right. Dr. Abaji.
Well, I also add that obviously we need more resources to better perform. We also want to encourage an improvement in health seeking behavior, because even sometimes the very little resources available are not being utilized, because you have a health center that does one delivery a month. Meanwhile, there are all babies around, so we want to ensure that people are using the services, and also encourage the traditional authority to be supportive, Queen Mothers, Mother's to be supportive in mobilizing more women for care, and also want to ensure, also as the media, to help us.
Right. And that's why we are
to
doing
improve this health-seeking behavior.
Okay.
We are having major challenges also from some religious bodies who are putting all kinds of stories around pregnancy, and it's one area that we tend to have a major problem. Some of them are conducting deliveries on television, and some
Pregnant women's stomachs are being stepped
stepped upon, and we are telling all kinds of stories why when your legs are getting swollen, they ascribe all kinds of stories to them. These are all things that tend to sway women to get the wrong health-seeking behavior. I think that will help us.
Right. So in the spirit of Christmas, here on Women's Voice, we'll give you the opportunity to wish your loved ones a Merry Christmas in advance before you go. Clara?
Okay, so I want to say Merry Christmas to my father, Mr. Sebwatin Atakemoda, and then to my household, my mother, Obaya, and to all my siblings and all my loved ones. And then to my CEO, of course, Siapa Kamara. Merry Christmas, all staff of St. Ghana. Merry Christmas to you all. And Ayiko for the hard work you've put in this year.
Dr. Abaji.
Well, Merry Christmas in advance to my wife and kids, my staff in the office, the Director General, and all the staff of Ghana Health Service for the big work that we are doing. Thank you.
Thank you so much all for being here on the show today. So Women's Voice today, we've been looking at reducing maternal mortality, the case of Northern Ghana. And my guest with me in the studio, I have had Dr. Patrick Abuaji. He is the Director of the Family Health Division at the Ghana Health Service. And I've also had Gladys Clara Osei-Boateng. She's the Director of Policy Advocacy Program at St. Ghana, joining us here for the discussion. As we do it, before we go on inspirational quotes, this one comes from Leah Kebede. She's an Ethiopian-born model and a maternal health advocate, and the quote says, "We should work to guarantee that there is a midwife or health worker by every woman's side during childbirth." End of quote. My name is Salikem Akola Chiapalu. We'll be back to do it again tomorrow. Many thanks for watching.
It's about exposing the vulnerabilities women face.
But you are in a peculiar situation. You are pregnant.
Yes. I've told that point already. My family is a small family, and my father too is old man. He cannot work again. That's why I'm pregnant and I come here.
It's about being ready to speak out for our own rights.
We are saying that surrogacy unregulated is dangerous for our society. The authorities should get up and put regulations in place. Otherwise, we are putting our young women at risk.
We are always striving to reach the top no matter what.
I was chosen not because I was a woman. I was chosen because when I went for the interview, I seemed to have everything that the Ghana Chamber of Mines wanted.
We are frank about who we are.
I deal with mostly women. Even though I deal with men, most of my clients are women. And you know, we women,
I don't know really.
And in today's world, we do have a say.
Actually, they are dead drunk. We don't have a voice. With that voice, we can change the world. With that voice, we can take command of our broken communities.
Women's Voice, weekdays on GBC 24 at 4 p.m. and on Mondays and Thursdays on GTV at 4 p.m. Women's Voice, articulating the issues affecting women and sharing their unique stories with the rest of the world.